PTMC is the world's first simple procedure using a balloon catheter developed by Dr. Kanji Inoue in 1982 for non-surgical mitral commissurotomy. The Inoue Balloon Catheter, IBC, is used for PTMC in mitral stenosis. IBC is inserted percutaneously over a guidewire via the femoral vein to dilate the narrowed mitral valve. The special hourglass shape of the balloon prevents slippage at the valve opening and ensures reliable valve dilatation. A single balloon allows gradual valve dilatation with adjustable inflation diameters. Repeated dilation is possible without changing the balloon catheter. The IBC set contains balloon catheter, syringe, and its accessories. Flush the balloon catheter inner tube with heparinized saline solution. Ensure that the alphabetical code on the W connector matches that on the syringe. Inject dilute contrast medium through the vent stopcock to fill the balloon inflating channel. When full, excess solution will flow out of the main stopcock. Lock the valves of both the main and vent stopcocks. Fill the syringe with dilute contrast medium to the proximal end of the red indicator bar, representing the minimum volume recommended for balloon inflation. Connect syringe to the port of the main stopcock. Open the main stopcock and slowly inject the dilute contrast medium to inflate the balloon fully through all inflation stages. Deflate the balloon by withdrawing the dilute contrast medium into the syringe, and inflate the balloon again with the same volume of dilute contrast medium. Using the ruler, measure the balloon diameter at the waist. Confirm that the injected volume produces the degree of inflation corresponding with the minimum diameter millimeter reading on the syringe. Withdraw the dilute contrast medium into the syringe. Repeat the same steps to confirm the maximum balloon inflation diameter. Once you inject the dilute contrast medium up to the proximal end of the red indicator bar, only the tip will expand. Open the main stopcock and deflate the balloon by withdrawing the dilute contrast medium into the syringe. Close the main stopcock and disconnect the syringe from the port of the main stopcock. Perform the minimum or maximum diameter test inflations slowly to avoid mesh tear. Fully insert the stylet into the balloon catheter to confirm the handling characteristics. During the procedure, maneuver the balloon catheter with the stylet. Advance the stylet to direct the balloon tip away from the valve orifice. Conversely, withdraw and rotate the stylet counterclockwise to direct the balloon tip toward the orifice. Withdraw and remove the stylet from the balloon catheter. Prior to use, the stylet may be manually shaped into a curve matching the anatomy of the patient's left atrium. Flush the inside of the balloon stretching tube with heparinized saline solution. Insert the balloon stretching tube into the catheter inner tube and luer lock at the hubs. Advance the catheter inner tube into the W connector. Place the pin of the inner tube into the slot in the W connector, then lock. The balloon will lengthen and straighten. After pressure measurement, insert the guidewire into the left atrium through the transeptal catheter. Remove the transeptal catheter, leaving the guidewire in place. Introduce the dilator over the guidewire to dilate the femoral vein puncture site and the interatrial septum. Remove the dilator. Insert the elongated IBC containing the balloon stretching tube into the left atrium over the guidewire. Avoid injury to or perforation of the myocardial wall to prevent possible cardiac tamponade. Echocardiography may be used to assist in passing the catheter through the septum and the valve orifice. When the greatest portion of the balloon has passed the septum and the tip of the balloon nears the upper wall of the left atrium, withdraw the balloon stretching tube from the IBC inner tube approximately 2 to 3 centimeters. This will result in the tip portion of the balloon becoming more elastic. Advance both the IBC and the balloon stretching tube approximately 5 centimeters and insert the unit archwise into the left atrium along the guidewire, thus passing the balloon section through the septum completely. Unlock the inner tube from the W connector of the IBC and pull out until resistance is felt, thus returning the elongated balloon to its original length. Advance the IBC further over the guidewire in the shape of the left atrial arch, maintaining the position of the balloon stretching tube. Remove both the guidewire and balloon stretching tube simultaneously, leaving only the IBC. Connect the syringe to the port of the main stopcock. The total amount of dilute contrast medium in the syringe must correspond to the desired balloon diameter, as seen on the indicator bar. Slightly inflate the balloon tip to facilitate passage through the mitral orifice. Inflate balloon tip according to the size of the valve opening observed during cardiac catheterization. If the mitral orifice is very small, do not inflate the balloon tip at this time. Insert the stylet into the IBC and direct the balloon tip into the valve opening. Maneuver the balloon catheter with the stylet. Advance the stylet to direct the balloon tip away from the valve orifice. Conversely, as the stylet is rotated counterclockwise and withdrawn, the balloon tip will move toward the orifice. Set the IBC in this position and pull the stylet back 3 to 5 centimeters. The balloon with the tip inflated will move forward and flow across the mitral orifice. Deflate the balloon by withdrawing the dilute contrast medium into the syringe after insertion of the balloon into the mitral orifice. Inflate the distal half of the balloon with dilute contrast medium injected into the main stopcock. Move the balloon back and forth 2 to 3 times inside the left ventricle to confirm that the balloon has not wandered into the porta tendineae. Seat the balloon on the valve opening by pulling gently. Inject the remaining dilute contrast medium quickly. During inflation, the waist of the balloon will center in the valve opening and prevent migration from this position. Once the balloon is fully expanded, the stenotic valve opening will enlarge due to the balloon volume. Deflate the balloon by withdrawing the dilute contrast medium into the syringe. After slowly withdrawing the balloon to the septum, insert the guidewire and immediately insert the balloon stretching tube into the catheter inner tube. To avoid damage to guidewire, it is recommended that the coiled portion of the guidewire remains outside the distal end of the balloon stretching tube during reinsertion of this assembly. Lure lock the balloon stretching tube and the catheter inner tube at the hubs. Advance the catheter inner tube into the W connector. Insert the pin of the inner tube into the slot in the W connector, then lock. The balloon will then lengthen and straighten. Withdraw the catheter and accessories altogether as one unit. After the balloon has been elongated with the balloon stretching tube, Do not disconnect the metal hubs from each other or from the W connector, unless the guide wire is in place and the coiled portion fully protrudes from the catheter tip. Do not advance the catheter inner tube into the W connector unless the balloon stretching tube has been inserted into the catheter inner tube and locked at the hubs. Failure to observe this caution may result in the catheter bending at an acute angle and subsequent damage to the device or difficulty in carrying out the procedure. Twisting of the inner tube lumen occurs when there is a rotation of the inner tube at its attachment to the W connector end of the Inoue balloon. It is very important to hold the W connector and not the inner tube during catheter manipulation. This will avoid inner tube twisting. It is equally important to hold the W connector and not the inner tube during manipulation of the stylet to direct the balloon. Abnormal balloon inflation is caused by a mesh breakage. The mesh breakage may be caused by overinflation of the balloon and rapid increase of inner pressure that may occur when the balloon is inflating in a heavily calcified mitral valve. Prior to the PTMC procedure, please refer to the instructions for use for safe and proper use of the device.